Stay in this type of hospital too long tend to have several things happen. Number one, that the doctors that are taking care of them specialize in patients who come in for the length of stay here and are doing all these things. So once you get down to establishing a treatment plan in a longer stay patient, those patients are on the bottom of the priority list of the doctors. And it's also those patients, because of the staffing, because of the conditions in a short-term hospital that are oriented towards quick move through, those are the patients that can get bed sores. Those are the patients that can have falls. Those are the patients that the families just don't understand what's going on. As I said, sometimes the doctors might even, I'm not trying to cast any bad names on any doctors, but sometimes they miss lab work on patients like this and they don't see things that are evolving. So there are a variety of things that sort of get missed when people stay longer in the hospital. You can pick up infections a lot more easily. You all could probably add to that list. So what we do is we specialize in implementing the treatment plan. All of our patients are long-stay patients. So we're very attuned to wounds. We're very attuned to infections, all the things that are adjunct, perhaps, to the central problem. If you come in on a ventilator, you don't want to get a wound or an infection, if you can help it. We all know that infections are very virulent these days, and they're sometimes hard to work with. But we're blessed at our hospital to have a nationally known infectious disease doctor as our president of staff, Dr. Wong. He's the chief of infectious disease at the VA hospital. So we have a very low infection rate. Wounds the same way. We have 4 nurses. All they do is check people. We have a 60-bed hospital in our case. All they do is look at skin integrity and take care of the. We do admit people with wounds. So they take care of the wounds and they check against, to make sure that they don't have any new wounds develop. So allowing patients time to heal. How many people, quick show of hands, how many people have heard, they pushed me out of the hospital? That statement said in the last 10 years. Yes? They pushed me out of the hospital. Some people have. How many people have never heard that? One troublemaker. So most people have heard that. What we do, and we see a lot of times, especially with, not so much with ventilators, obviously on a ventilator, there's a reverse problem. They won't let you go to a specialty care hospital, they hold on too long. But infections, that's a big one of these, because we see a lot of patients, they do some lab work and they put you on antibiotics, and then next thing you know, okay, you can go home on that, or go to an infusion center, or go to a nursing home. God, help us there, we don't want to do that. Then we realized that it really didn't do the trick. So we have to bring the patient back in, tweak the antibiotics, and try again. Very often in the case of a nursing home, they're saying, okay, you got 2 IV antibiotics. So one of them is every 12 hours, one of them is every 6 hours. They're saying, we can't do that. Doctor, can you change them all to every 12 hours? Well, the doctor might do that to get a patient to a nursing home. My job is to tell the doctors, if you think it should be done every 6 or every 12 hours, that's what you need to do, we will do it. So allowing the patients time to heal appropriately. And simplifying the treatment through protocols and treatment teams. If you come to our hospital 2 days a week, it used to be Tuesdays and Wednesdays, I think it's Tuesdays and Thursdays or Wednesdays and Thursdays now. Our hospitalists, our hospital hired doctors are there all day, have 2 teams, a blue team and a yellow team. 1 doctor and 1 group of people on that, and 1 doctor and 1 group on that. We do interdisciplinary treatment teams weekly for that 3 to 4 week stay that patients are with us. And we start as though the patient just came in the hospital. Okay, you came in with this level of functioning, lower level of functioning. Week 1, week 2, week 3, week 4. You want to be here and be discharged, right? You want to go home, preferably. At the end of week 1, when we're doing our interdisciplinary team meetings, we found that you're not here, but you're sort of veered over here. the whole treatment team, doctors, nurses, respiratory therapists, PT, OT, speech, department heads, clinical dietitians, pharmacy, the whole group comes together and says, this is what we need to get you back on track. And that's what we do every week. Some people's track sort of looks like the DNA double helix, you know. You ever seen the DNA strand sort of goes like that? But we get them back on track. And then our average length stays a little longer. Right, so that's the STAC, LTAC comparison. This is the skilled nursing facility, nursing home versus the LTAC. We couldn't be any further apart than that kind of facility. This facility don't accept vent or complex wounds or extensive antibiotics. They typically after a fall or broken hip or a stroke is why patients typically go to sniffs, although any of those things could result in health action. Patients may be ambulatory, they may not. Medicare covers a 100 days episode with 20 days of full pay, followed by 80 days of partial pay. The Anthems of the world, the Sigmas, they might, if you have a secondary insurance, they might pick up the difference between the 20 and 100 day. You got to meet this criteria. There is a criteria for that. And this is weekly or monthly visiting of a doctor. They may not see you for, when my mom was in a nursing facility, I was in private practice for years, did a lot of work with nursing facilities. Very rarely do you see doctors and nurses. So LTAC, many patients need ventilator weaning or the chance to wean. So we're offering a chance, we can't guarantee. Our current statistics are at the last 2 quarters, we have an 85% wean rate this last quarter that we, which was the first quarter, the most recent that we've recorded for this year. We're just about to do quarter 2. Last quarter of last year was 87%. The national average is 42% for our type of hospital. So we've got a very high weaning rate. So we take complex respiratory patients. They could be patients with on ventilators, but it could be trach collars. Patients with trach collars that are over 40%, or infections that require suctioning every 2 or 3 hours. That could do it right there. Or antibiotics for multiple antibiotics for more than a couple of weeks. If it's less than a couple of weeks, we wouldn't take you to another level of care for that. So the respiratory complex could be a lot of things other than ventilator. Multiple IVs, antibiotics, multi-system failure. They're typically bed-bound or on transfer. 99.9% of our patients come from other hospitals, some come from home. 99.9% come in an ambulance. And the ambulance is usually an advanced life support ALS ambulance, so the highest level of ambulance transport. Medicare days uses acute days just the same as any other hospital. So if you come into Chippenham, you're here for for a month and a half on a ventilator when you should have been here for, what do we say, 12 days, and you come over to us, your copay that was due for hospital copay is covered here at this hospital, so there's not a secondary, not a second copay. And we have, of course, daily physician assessment. We have 24-hour a day, in our case, at this type of hospital, 24-hour a day on-campus doctors. So we have 12-hour a day, 2 hospitalists, pulmonary doctor, 2 hospitalists, and a physician assistant. That's 4, right? I'm losing track of my count. 4, all during the day. The hospitalists are 12-hour shifts, and then the other 12 hours we have advanced practice fellows, mostly from MCV, and already doctors. They're studying to be pulmonologists or cardiologists or something else, advanced practice.
I have a question.
Yes, ma'am.
So, something you just said.
Yes, ma'am.
So they're not they're students, or?
No, the night docs are docs. They're physicians. They're MD. They're internal medicine doctors. But once you're an internal medicine doctor, you become a pulmonary doctor,
right.
You have to go back and to school again,
right.
and get a fellowship in pulmonary medicine,
Right.
or gastroenterology, or surgery, or any other of the specialists start off as a doctor and then have another doctor's degree. It should be doctor degree number 2. We should call it that. So they've gone to school forever. So we have, usually they don't treat patients so much. They're there for emergency. We call them dozing for dollars. They have a place to sleep.
Right. So all your, like, the pulmonary doctors are from NCB, is that like?
No, our pulmonary doctor is actually our doctor, hired by us.
Oh, really?
They don't come and go during the day. Some of the specialists, the consultants, like surgeons, cardiology, psychiatry, physical medicine, rehab docs, they go and come. But the pulmonologist is there with us during the day, as is our hospitalist.
Do you, by chance, y'all use Dr. Teresi?
Dr. Teresi is with Pulmonary Associates of Richmond.
Mm-hmm.
That practice does a lot of referring to us, and we see a lot of their patients. Some of the doctors don't believe in this level of care. And Dr. Teresi's one of them. Although we keep trying to get him to come over and see us.
Oh.
Dr. Polsky, big supporter, Dr. Hay.
Can you refer us to another?
You said Dr. Hay is supporting it?
Well, yeah, I mean, all these doctors are good, and I wouldn't want to get into a suggestion.
No, but I mean.
Well, yes, it's just a philosophical. Let me back up a little. When I was, years ago, I was a case manager. Does everybody know what a case manager is? So, case managers in the hospital. Years ago, I was a case manager, and in this hospital, in the 80s. And in the 80s, they started a thing called rehab hospital. And I remember the doctors telling me back then, why would I send a patient from Chippenham over to Fitzhugh, which is a Nova rehab hospital there, or Shelton Arms, because we have, because they had a stroke, because we have physical therapy, occupational therapy, and speech pathology, and a neurologist here, and we can do perfectly well from here. Well, anybody knows anybody that's been in rehab knows that that's sort of absurd today. No doctor would say that. What's the difference between then and now? It's a learning curve. People have to get to feel comfortable with the situation and begin to sort of get the feel of how to use it. And some people never did. So, and that's okay. I mean,
Do you have to have a doctor